Chapter number 4: The Traditional Approach to Treating Adolescent Idiopathic Scoliosis. For much of modern medical history, the treatment of adolescent idiopathic scoliosis, AIS, has been centered around managing the spinal curvature itself, with a primary focus on mechanical correction. Traditionally, AIS treatment strategies were based on the size of the spinal curve, the patient's skeletal maturity, and the risk of progression. When curves measured less than 25 degrees, most physicians recommended simple observation, scheduling periodic x-rays to monitor any changes during periods of rapid growth. If a curve progressed beyond 25 degrees, bracing became the standard recommendation. The goal of bracing was not to reverse the curve, but to prevent further progression. Rigid orthotic devices, such as the Boston brace, were worn for up to 23 hours per day, often for several years, until skeletal maturity was reached. For severe curves, typically over 45 to 50 degrees, spinal fusion surgery was advised. This procedure involved realigning and permanently fusing the curved portion of the spine using rods, screws, and bone grafts to halt curve progression. While often successful in preventing further curvature, spinal fusion came with risks, including reduced flexibility, surgical complications, and potential long-term back pain. Throughout this traditional framework, little attention was given to the biological, neurological, or systemic factors contributing to AIS. The spine was viewed in isolation, and treatments focused solely on structural outcomes rather than underlying causes or overall body health. Today, growing awareness of scoliosis as a complex whole-body condition is reshaping these long-standing approaches. A missed opportunity. The traditional wait-and-watch approach to early-stage adolescent idiopathic scoliosis, AIS, where patients with mild spinal curves are simply monitored over time without active intervention, represents a significant missed opportunity for influencing the course of the condition. While this strategy was developed with the intent of avoiding unnecessary treatment for curves that might never progress, it inherently assumes that scoliosis is a passive structural anomaly rather than an active dynamic process. In reality, scoliosis is often a progressive condition fueled by underlying biological, neurological, and biomechanical imbalances, especially during periods of rapid adolescent growth. Waiting until a curve worsens before initiating treatment ignores the crucial early phase when the body is most adaptable and responsive to corrective efforts. Research has shown that smaller curves are easier to manage and potentially reverse when addressed proactively. Once a curve progresses beyond a certain threshold, commonly cited as 25 degrees, the risk of further progression significantly increases and treatment options become more limited and invasive. Early-stage intervention, including targeted rehabilitation exercises, neuromuscular re-education, hormonal balancing, and nutritional optimization, can help address the root factors that contribute to curve progression, such as poor postural control, muscle asymmetry, and systemic imbalances. Observation alone does nothing to stabilize or strengthen the spine, leaving a child vulnerable during their most critical developmental windows. Furthermore, the emotional toll of a watch and wait approach, marked by anxiety over worsening news at each follow-up visit, can have lasting psychological impacts on young patients and their families. Empowering early-stage scoliosis patients with proactive, non-invasive treatments not only improves the likelihood of preventing severe curvature, but also fosters a sense of agency, resilience, and health ownership. Modern research increasingly supports early intervention models that use dynamic, patient-specific strategies rather than passive observation. Programs that integrate scoliosis-specific exercise therapies, balance training, and whole-body wellness approaches have shown promising results in slowing, halting, or even reducing curve progression when implemented early. Given the evolving understanding of scoliosis as a whole-body condition influenced by genetic, hormonal, and neurological factors, there is an ethical imperative to rethink the outdated reliance on observation. When scoliosis is detected early, clinicians have an invaluable opportunity to intervene when the body is most responsive and the structural changes are most malleable. Waiting until a child's curve reaches surgical thresholds before acting, while well-intentioned, often transforms a manageable condition into a crisis that requires bracing or spinal fusion surgery. Therefore, abandoning the passive wait and watch mindset in favor of proactive, individualized care models represents a critical advancement in scoliosis treatment philosophy. By embracing early intervention, the medical community can better align treatment strategies with the biological realities of scoliosis progression, ultimately offering patients the best chance for optimal long-term outcomes and an improved quality of life. Treating the symptom, not the condition, spinal bracing has long been considered a standard non-surgical treatment for adolescent idiopathic scoliosis, AIS. Yet it is increasingly recognized as only a temporary and largely superficial solution that does not fundamentally improve spinal curvature or alter the course of the condition. The primary goal of bracing is not to correct scoliosis, but to attempt to prevent further curve progression during growth. The theoretical basis for this approach lies in the Hütter-Volkmann principle, which suggests that bone growth can be slowed on the side of the vertebra, experiencing increased compressive forces, and accelerated on the side with less pressure. Braces aim to apply external pressure to the convex side of the spinal curve, thereby hoping to manipulate this principle and slow or halt worsening asymmetry during critical periods of skeletal development. However, this strategy fundamentally misunderstands the nature of scoliosis, focusing exclusively on the most visible symptom, the spinal curve, while ignoring the complex, multi-system dysfunctions that drive the condition at a biological level. Bracing does nothing to address the underlying causes of scoliosis, such as genetic predispositions, neuromuscular imbalances, hormonal dysregulation, or proprioceptive deficits. As a result, its effectiveness is inherently limited. Numerous studies and patient experiences reveal that while bracing may temporarily stabilize a curve during active growth, it rarely leads to permanent improvement, and many curves continue to progress once bracing is discontinued. Additionally, bracing can introduce unintended consequences, such as muscular atrophy, restricted respiratory function, and psychological stress from long-term device wear, further compounding the challenges scoliosis patients face. The rigid external support provided by a brace does not teach the body how to achieve natural dynamic postural stability. Instead, it creates dependency on a mechanical device without promoting the neuromuscular re-education necessary for long-term spinal health. Moreover, bracing outcomes are highly variable, with many patients experiencing curve progression despite full compliance with wear schedules. This inconsistency underscores the reality that scoliosis is not simply a matter of mechanical misalignment, but rather a manifestation of systemic imbalance that cannot be corrected by external force alone. Modern understanding of scoliosis points toward a need for comprehensive, whole-body approaches that engage the patient's neurology, musculoskeletal system, endocrine function, and genetic blueprint. Early-stage interventions focused on active self-correction, targeted exercises, hormonal support, nutritional optimization, and neurological retraining offer a far more promising path toward sustainable improvement. In this context, spinal bracing represents an outdated philosophy of care, one rooted in symptom suppression rather than true rehabilitation. Continuing to rely on bracing as the cornerstone of non-surgical scoliosis treatment not only limits patient outcomes, but also squanders valuable opportunities for meaningful early intervention. True scoliosis care must move beyond attempting to hold the curve in place and instead aim to reprogram the underlying systems that contribute to spinal stability and asymmetry. Only through addressing the root causes of scoliosis, rather than merely its external presentation, can we hope to offer patients a future of lasting spinal health, improved function, and greater quality of life. Is the cure worse than the condition? Highly invasive spinal fusion surgery for scoliosis has long been considered the definitive treatment for severe spinal curvatures, particularly those exceeding 45 to 50 degrees. This procedure, which typically involves the permanent fusion of multiple vertebrae using metal rods, screws, and bone grafts, aims to halt further curve progression and stabilize the spine. While fusion surgery can dramatically reduce the degree of curvature in the short term and is sometimes necessary to prevent life-threatening spinal deformities, it is not without serious risks, both immediate and long-term. In the short term, patients undergoing spinal fusion are exposed to the inherent dangers of major surgery, including complications from general anesthesia, significant blood loss, infection, nerve damage, blood clots, and adverse reactions to implants or bone graft materials. Surgical site infections, in particular, can be devastating, sometimes requiring removal of hardware or additional surgeries. Spinal cord injury, although rare, can occur during instrumentation, leading to partial or complete paralysis. Recovery from spinal fusion is long and arduous, often requiring several months of restricted activity and physical therapy to regain basic function. Beyond the initial recovery, the long-term implications of scoliosis fusion surgery can be profound and life-altering. Chronic pain is one of the most common long-term complications, affecting a significant proportion of patients. Despite achieving structural correction, many individuals report persistent back pain, stiffness, and reduced spinal mobility, which can severely limit their daily activities and quality of life. The fused sections of the spine no longer move naturally, placing increased biomechanical stress on adjacent unfused segments, a phenomenon known as adjacent segment disease, ASD. Over time, these compensating areas can develop degenerative disc disease, herniations, arthritis, or new curvatures, often necessitating further surgical interventions. Moreover, the irreversible loss of spinal flexibility can impair athletic performance. Simple activities like bending or twisting, and even natural gait patterns, which may accelerate musculoskeletal wear elsewhere in the body, such as the hips, knees, and feet. One lesser known but increasingly concerning issue with long-term spinal implants is the gradual corrosion and breakdown of the surgical hardware itself. The metal rods, screws, and connectors used in scoliosis fusion are typically made from titanium, stainless steel, or cobalt chromium alloys. Although these materials are selected for their strength and biocompatibility, they are not immune to the mechanical and chemical stresses inside the human body. Over years or decades, microscopic wear, fretting, and corrosion can release tiny metal particles and ions into surrounding tissues and the bloodstream. This phenomenon, called metallosis, can trigger local inflammatory responses, pseudotumor formation, tissue necrosis, and systemic symptoms such as chronic fatigue, cognitive impairment, or allergic-type reactions. Studies have documented elevated levels of metal ions such as titanium, cobalt, and chromium in the bloodstreams of long-term fusion patients, raising concerns about potential systemic toxicity and long-term organ effects, though this remains an evolving area of research. Furthermore, revision surgery to remove or replace corroded or failed hardware carries even higher risks than the initial procedure, with greater chances of infection, nerve injury, and poor outcomes due to scar tissue and compromised spinal structures. Psychologically, many patients experience significant emotional and mental health challenges following spinal fusion. Feelings of regret, depression, anxiety, and frustration are not uncommon, particularly among young patients who are unprepared for the lifelong physical restrictions and chronic discomfort that can follow surgery. The belief that surgery would fix their scoliosis is often replaced by the realization that their spine and their life has been permanently altered, sometimes without achieving the level of pain relief or function they had hoped for. Given these risks, it is increasingly important for patients and families to fully understand that spinal fusion does not cure scoliosis. It merely stabilizes the curvature in exchange for significant functional and biological costs. While in certain severe or rapidly progressing cases, fusion may still represent the best available option, it should never be presented as a benign, simple solution. Alternatives that focus on earlier, proactive, non-surgical interventions, including scoliosis-specific exercise programs, neuromuscular retraining, and addressing underlying biological drivers, deserve much greater emphasis within the scoliosis treatment landscape. By shifting the focus from crisis management to prevention and whole-body health, the need for highly invasive surgeries and their associated complications may be significantly reduced. In summary, scoliosis fusion surgery is a highly invasive, high-stakes procedure that carries serious short and long-term risks. Immediate surgical dangers include infection, nerve damage, and recovery challenges, while chronic pain, loss of spinal mobility, adjacent segment disease, and systemic issues related to hardware degradation threaten long-term health and quality of life. The growing awareness of metal ion release and its potential systemic impacts further complicates the risk-benefit analysis for fusion surgery. Patients and families must be thoroughly informed and actively involved in decision-making processes, weighing all available options before committing to a procedure that permanently and profoundly alters spinal function and personal health.